Hi, Dr. Briggs. Hi, Dr. Briggs, can you hear me?
Yes, I can hear you. And hold on a second. I'm going to make sure my computer sound is off. It is. I like to be on my iPad for video, and then I will share the PowerPoint from my computer, which is why there's two of me on here.
Good afternoon, everybody. I'm Michelle Brock. I'm with the Physician Liaison Program, and I have the pleasure today of welcoming you to our next KCH Pediatric Town Hall. The focus is on youth suicide prevention in a primary care setting, and we've got two wonderful speakers here for you today, Dr. Sadir and Dr. Briggs. But before we get started, I'm just going to go over some general housekeeping information. Dr. Briggs, can you just advance the slide? And just so that we can better facilitate networking and communication, if you all don't mind, in the chat box, please enter your name, your title, your organization, and your email. And then I'll kind of remind you of that throughout the conversation today. That way I can follow up with you and I can send you PDFs of the slides and links to the, to the Zoom recording that you can share with others at your team. If you have logged in and you're not logged in under your first and last name, if you could change your, acronym or initials to your from your username to your first and last name, that helps us figure out who's in attendance. So that would be much appreciated. All of your microphones are muted and they're going to remain so until the end of the presentation, where we're going to be having questions. And then if you need to unmute yourself, you're welcome to do so at that time. And then please keep yourself in speaker view so you can always view the speaker. And as a reminder, I will send out all the PDFs and the link to the Zoom recording at the end of the call. So this is a community-wide forum, so just keep that in mind. So any patient-specific information, please try to avoid those conversations, but you can ask general questions as well. So without further ado, I'm going to turn it over to Dr. Scotty Day, our physician-in-chief for Kentucky Children's Hospital. Thanks for joining.
Thanks, Michelle. We appreciate everyone to be on today, and also appreciate the dedication that you guys take during this hour to kind of learn more, both about a lot of mental health issues. I feel like that we probably called on Dr. Sadir more often than she probably has time to say yes to, and Dr. Briggs as well. So I'm very appreciative of their time. I'm not going to talk a whole lot other than to say that really what we want to talk about is really to discuss, kind of look at the prevalence of youth suicidality, as well as look at kind of some suicide risk assessments and just some care and communication plans. We're also well aware of the issues related to the mental health referrals and how challenging it can be to get children in, and we are actively working on that. As an organization, as a children's hospital, we've engaged with a consultant working with various entities to try to determine how we are going to approach and manage the ongoing, what I would say, epidemic around adolescent and child mental health. And once again, we do our best to give you the information today, and I'm going to turn it over to both Dr. Briggs, who is a licensed psychologist in our adolescent medicine division. She has led our school programs in many, many ways. She's a leader both locally but also nationally. In addition to that, Dr. Sadir, who's our chief of the Division of Adolescent Medicine. She also has a large leadership role with the Adolescent Task Force for the American Academy of Pediatrics. So I'll turn it over to you guys.
Hi, thanks for joining all of us today. I am going to open us up, and I think the first item on the agenda was to talk about prevalence, but I also want to take a moment to start off in a hopeful way, because I know when we talk about the current state of children's mental health, it can feel sometimes like doom and gloom. So I just want to start off with a focus on what do our adolescents need and how can we help protect them. So the two things they need, the first one is to feel understood. So when talking with adolescents about mood, about their mental health, about depression and suicide, we need to make sure that we take time to understand where they're coming from and empathize with how they're feeling. The second thing adolescents need is freedom from judgment. They are very afraid in some ways, right, of what other people think of them, always worried and thinking about what other people think. And, when we talk with them, we need to help them feel safe to open up and, free from us judging or putting labels on them. And I think, these are two things that have guided me as a psychologist in working with adolescents, that were actually shared with me by my clinical supervisor. And I think, they're two mantras to keep in the back of your mind when working with adolescents who are struggling with mental health. And then what protects our adolescents from suicidality? I have connectedness bolded here because I think this is something that is so critical for adolescents. If you think about their main developmental task in this age group is to safely move away from their family and into a peer group and into a community. And so one of the things we lost with the COVID pandemic out of necessity, out of safety, was some of this connectedness. And I think sometimes, we thought, adolescents could connect over social media or online. And they do, and they can, and some of that's fine. However, I think, in-person connectedness is also a critical protective factor for them. Other things that we look for that protect adolescents, from risk from suicide is regular school attendance, ensuring they have access to healthcare, which is why we feel strongly about providing outreach clinics in schools, having them have a strong therapeutic relationship with a mental health provider, having some coping skills, feeling some control, being able to tolerate the little hassles, and having some problem-solving skills. In addition, to being connected to a faith if that's part of their family's belief system. So I think, some of these things we teach directly in therapy when working with youth, but I think that piece of connectedness is important to hold close. And then here too, I have some things, there's multiple risk factors for suicidality, but I have some things bolded here too, for a reason. So one thing that I think is easy to miss is irritability and aggression as a risk factor for suicidality. Our teens who act out tend to frustrate us and, tend to get in trouble, right, at school. They may end up in the juvenile justice system. They may end up being suspended. And sometimes we forget to stop and think about what's going on the inside, right? Are they in a fight response due to pain they're experiencing on the inside? And are we missing an opportunity to care for them? And so I think, when we have a youth who's acting out, it's important to stop and think about what's going on. Another kind of critical factor that places youth at risk is, feeling like they're a burden to others, or feeling like in some way they're a burden, to their family. And so here I think messages of just kind of unconditional positive regard, an unconditional willingness to love and help and support a child is critical to help protect them against that feeling of burdensomeness. Loneliness, again, is another factor, I think, especially to pay attention to for adolescents, because again, that developmental task of connectedness is so important. And access to lethal means, which we'll talk about here in a little bit. Access to guns, especially, is a key risk factor. The leading cause of death right now for children and adolescents is guns. And then also any, recent losses. I think this was a risk factor that was, accelerated during the pandemic as well. And then, exposure to suicide, either in the community or through their friend group or through family. And others as prior attempts too, I think is important to pay attention to, as well as that is a significant risk factor too. And there are also important demographic variables to consider, I think, when thinking about risk for suicide. One is gender. So females are more likely to attempt suicide. Males are more likely to die by suicide. And our transgender youth are much more likely to seriously contemplate, attempt suicide and die by suicide at a higher rate. And then, sexual orientation also presents a significant risk factor. Our youth who are gay or bisexual or pansexual are at a higher risk of attempting suicide. And then I think too, we have to also consider the intersection between these variables. So white youth and Native American or Indigenous youth are, well, especially Native American Indigenous youth are at the highest risk of suicide, followed by white youth. But then when we factor in transgender identity and sexual orientation, our youth of color are at a higher risk. So youth who are of color and then also have a transgender identity or are gay or bisexual are at a higher risk of attempting suicide. Age, we're concerned about suicide, of course, and of course in youth, because it is the second leading cause of death in our youth. And then also rural location tends to present a risk factor as well. And some of these things, I've spoken to already, but I think it hits me, and I hope it hits others as well, that the second leading cause of death in our adolescents is suicide. And sometimes I think about what if that was a different disease? What would our response be like? And what does that say sometimes about, our attention to mental health and suicide? We should be putting in, I think, a significant lift, right, in addressing adolescent mental health and suicide, given, how significant of a risk factor it is to mortality in this age group. I think another thing to think about and chew on is that when surveyed, about 20% of our youth report seriously considering suicide. That's 1 in 5. And we find, when we screen students across schools, that number holds up. And so I think it's also, it's also relatively common and something we need to be prepared to address. Another thing that's concerning is that the rate has gone up steadily since 2007. So what is going on in our community and in our culture that is driving this, and how do we address that, I think is an important question. And again, guns are the leading cause of death for youth, and they're used in about half of suicide deaths. So access to firearms is an important variable to consider and talk about as well. Something, that kind of, there are many experts within Kentucky on suicidality and suicide and mental health in youth. Something that, inspired Dr. Sadir and I to think about talking to all of you is that we looked at an article where we saw that Kentucky is number 18 of 50 in terms of the suicide rate, and it has jumped up from number 32 out of 50. And so I think it's something for us, to pay attention to locally. So in 2019, prior to the mental health crisis that was triggered by the pandemic, we had 130 children in our state between the age of 5 and 25 die by suicide. And I think that really struck us, and it inspired us to be here talking to you about this. So how did the pandemic impact all of this? I think something to consider is that there was a recent study that found that youth who felt close to people at school during the pandemic, somehow still felt connected to people at school, were less likely to attempt suicide. So again, that piece of connectedness is a really important protective factor. And one of the challenges of the pandemic was to support that connectedness when we had a mix between going back and forth between in-person and virtual instruction. And the pandemic was really stressful, and I think really and is very stressful for our youth for a multitude of reasons. And we have here that depression, self-harm, and suicidality all increased. Nearly half of youth reported being depressed at some point during this time period, and over a third experienced poor mental health during this time period. So when do we worry, or when do we start to worry? I think there are, again, I have things bolded in here that I think are important to attend to that we sometimes miss. In that I'm not going to pretend to be perfect here either. There have been things that I have missed as well, and I think these are the things that stick out to me. And one is, again, that acting reckless, engaging in high risk activities. When our youth are doing that, I think sometimes, again, they get dismissed as being delinquent or just acting out, but depression can be a driver of that behavior. Rage, I think, is a time to worry, because again, that rage can be directed towards the self and is part of the fight and flight response that you get with a mood disorder. If you see, dramatic shifts in mood, that again is something to pay attention to. And then, of course, threatening to kill oneself. Of course, seeking out means to kill oneself. Practicing lethal behaviors. So are they doing things that kind of mimic lethal behaviors as a way to kind of, reduce the barrier to ending their life? Seeking out means to kill oneself. So I think, a couple cases, that I have seen, right, where an adolescent starts to gather pills, or that's a serious concern. Withdrawing from others is a point of worry, again, because that connectedness is so important. And substance use can play a role as well. Oops, I went backwards. But I think, and I want to take a shift here and talk about, so, we're worried about our, perhaps, an adolescent we're working with. How do we talk to them about this? And I think sometimes a barrier to talking to youth about this is being afraid of saying the wrong thing. And there are certain ways of phrasing things that are more helpful, and we'll talk a bit about those. But I think the most important thing is not to let the fear of saying the wrong thing keep you from saying anything. The most important thing is really to ask the direct question, right? Are they having thoughts about ending their life? And I've had more than one teen, say, if you hadn't asked me that directly, I wasn't going to tell you, right? They want you to ask the direct question. They don't want you to beat around the bush. They don't want you to kind of phrase it and package it up. The best thing to do is to ask directly. And I think sometimes there's a fear too that asking will somehow put the idea in their head. And really, multiple research studies have shown that it's safe to ask. It's not going to put the idea in their head. If I ask a youth, are they thinking about ending their life, and they aren't, they'll be, I'll get it, absolutely not, right? It doesn't make them start to think about it. And even, I think, even young kids, right, can be at risk. And I think it's okay to ask them too. Dr. Sadir and I work, mostly in the adolescent world, but I have a 7-year-old I took to an appointment, and the physician asked my 7-year-old if they had thoughts about ending their life. And my husband was like, isn't it isn't it kind of young to be asking that question? And I said, unfortunately not. And you know what? It didn't hurt my 7-year-old. My 7-year-old was said, absolutely not. And moved on and didn't ask anything more about it. So I think, we can't let that fear of asking or saying something keep us from finding out if one of our youth is really struggling. Now, in terms of some helpful ways to ask here, we're kind of using a pairing of, validating and asking the question. So the validation piece here is sometimes people in your situation, if they're going through a particular situation, lose hope, right? So we're validating how they may be feeling. I'm wondering if you have lost hope too, right? And that can provide an opening to talk about hopelessness, which then can provide an opening to ask the direct question, right? Are you thinking about ending your life? Or have you ever thought things would be better if you were dead? Have you ever, wished you would die and never, or never wake up? Have you thought of hurting yourself? And again, this question has, the validation at the front, which kind of lowers the defensiveness to provide an honest answer. So with this much stress, right, have you thought of hurting yourself? Or really, it's fine to say, have you ever thought about killing yourself? And actually important to ask that direct question too. So I think, in talking with youth, an important thing to remember is to validate how they may be feeling. Again, we go back to one of the things that an adolescent needs is to feel understood. So we can start by validating how they may be feeling hopeless, or how they may be struggling, or how they may be in pain, right? To show that we understand, reduce their defensiveness, give them an opening to respond to us honestly, and then ask them the direct question. One thing we want to avoid doing is dismissing how they may be feeling. So we don't want to, say things like, oh, these people over here, they have it so much harder too, or, to say, oh, you have such a great life. Like, how could you feel that way, right? We want to validate and show that we understand, and we don't want it to dismiss or minimize how they may be feeling in that moment, even those comments come from the intention of trying to help them feel better. And again, there are some things not to say and some things to say instead. However, I would say, again, don't let the fear about saying the wrong thing keep you from talking, right? Try and correct yourself. Try and make sure you're focusing on how to say things. But the most important thing is to ask and talk about it. So what to say when talking about suicide with someone or with the youth is to say they died by suicide. We want to avoid the word commit because that makes it sound like a crime. Instead of saying their death was a cry for help or they did this for attention, because we do not want to assume intent or dismiss or minimize suicidal behavior, we say they were in pain, right? And they took an action. We do not want to use the language of successful or unsuccessful because that indicates an achievement. We want to, again, say they died by suicide or they attempted suicide. When talking about reducing access to lethal means, we don't want to say we want to maybe try and avoid the word restriction because that's kind of viewed as a punishment or loss of privilege. We want to say, we want to make sure the home environment is safe. We want to make sure that, lethal means are stored and secured safely. And again, when talking about the prevention of suicide, we want to say that it can be prevented, but we would shy away from saying it is preventable because that can be harmful to suicide loss survivors. Nor is it accurate. It can be prevented, but getting to 100% prevention, right, would be an aspiration and not a reality. All right, and then I will hand it over to Dr. Sadir, who will talk to you a bit about screening and assessment within primary care practices. And holler at me if I forget to advance the slide, Dr. Sadir.
All right, thank you, Dr. Briggs. So next thing we're going to talk about is screening. And this is where I know we can have a lot of questions around when should we do screenings, how often we need to do screenings. And this is where we need to start thinking about how we approach screening for suicide in a primary care setting. So the big thing for teens is, and as Dr. Briggs had mentioned, teens don't come to us and tell us that they want to kill themselves. They're never going to come and talk to us about how they feel, and they don't even talk about even their unsafe sexual practices. And they come to our clinic for a sore throat, and they basically want an STI check. So when it comes to mental health concerns, they are very reluctant to talk and come to the practice talking about it, I need help. They may come and present and say, hey, I have abdominal pain, I have headache or something else, because they know that when they're presenting with somatic complaints, somebody will sort of pay attention to it, or maybe perhaps their parents will pay attention because that gets the attention. But when it comes to mental health concerns, for some reason that doesn't get the attention. And as a result, a lot of teens at risk for suicide, they pass to the healthcare system and they go unnoticed because we don't ask them that question directly. And I share this story, and I think that's kind of one of the things that has really driven a lot of work around it, how losing a teen and to suicide when the kid was seen in the healthcare system a couple months prior to this and who had no prior history of mental health concerns. And this is true. While there are risk factors, or depression is a risk factor for suicidality, but not always we uncover those risk factors. And all we know is that they come to the ER dead. And so these are some of the stats, and these are some really concerning stats that we have, that 80% of teens visited the healthcare provider within a year prior to death by suicide, and 49% of the youth had visited the ED within the year before their death. 38% of teens had a contact with the healthcare system within 4 weeks before their death, and 34% of people age 15 plus years had a contact with the healthcare provider in the week before their death. So they all come through our healthcare system. They are seeking care in a specialty clinic. They are coming in primary care setting. They are going to urgent care. They're coming to ER for all kinds of things. And in fact, I can share a story where had a kid I saw 2 years ago, 2 years prior to when they died by suicide, for a health checkup, and depression screening was perfect, negative, never saw this kid after that in the clinic. The kid had been seen in another subspecialty clinic for other reasons, not related to mental health, and was last seen a couple months before, just a couple months before they were seen in a clinic, and then they just presented to the ER dead. And so that raised a lot of questions. Did we fail this kid as a healthcare system? Did we fail this kid? And obviously there are all kinds of questions around that. But this really sort of highlights the issues that we are dealing with, that these kids are seeking care. We are taking care of them, and we're just not talking to them about how they're feeling or if they are having these thoughts about hurting themselves. Next slide, Alyssa. And so just that missed opportunities that we have. So we all are aware of the AP recommendations. I think everybody does a great job with annual screening. We do 12 and older depression screening. We have PHQ-9A. Kids who are coming to us for an annual checkup, we do it. This is a great quality metrics that we have. The Medicaid directed payments, value-based system. I think there's a lot of push for that, which is great. That's a good start, that at least we are making an effort to screen our patients for depression. And obviously PHQ-9 modified for teens has some questions around suicidality. So a lot of times we're doing annual visits, and we're doing these screenings for when a parent is concerned, or when we have teens coming to us and telling about their behaviors. And a lot of it is more reactive approach. Proactively, annual screenings, and reactive approaches when there's a concern. But again, we are missing those kids. And the other study that was done recently also compared, is PHQ-9A the best screening tool for suicide? And they actually compared the ASQ, which is the Ask to Suicide screening questions, and they compared the PHQ-9A, and they did this study across 12 primary care clinics. And what they found was that while PHQ-9A really uncovered a lot of suicidal thoughts, but there were a lot of missed screening. So what they found was that the kids who reported they did not have suicidal thoughts in the past month on PHQ-9A, 13% had a positive ASQ result. And so now the recommendation has kind of moved into that we may be wanting to include ASQ as part of suicidal screening. So in our clinic, what we've done is, and honestly, I attended this conference and learned a lot about zero suicide framework, the ASQ. So the first thing I did in our clinic was so we do routine screenings for PHQ-9A and anxiety. So what I did was I had a PHQ-9 screen, and then we added the ASQ. And so we have a one form that we had teens complete with PHQ-9 in the front, ASQ in the back. As a result, we are doing this together. And this is a great way to screen your patients for suicidality, kind of combine these two forms. And this is really a quick screener. It's really validated for kids 10 to 24. It's 20 seconds. It has 5 questions, and it can be used in any settings, inpatient, ER, ambulatory settings. And the best part of it is available in many languages. And if you go on their website, it's the National Institute of Mental Health, and we have resources towards the end. You can pick any language. It's available in Arabic, it's available in Hindi, it's available in Spanish, it's available in Portuguese. I mean, there's so many languages that it is available in. And this can really help kind of reach out to other or non-English speaking teens and help to screen them for suicidality. Next. And these are the other 2 screenings that I'm sure everybody's aware. We have the Columbia Suicide Severity Rating Scale that is pretty much used. And now has been used in a behavioral health unit. And there's another one that's called the Patient Safety Screener that is also kind of available. And there are links attached in the slide that can kind of give you the information about the Patient Safety Screener, which is a 5 questions. And the Columbia Suicide Severity Rating Scale is also a validated tool for screening kids for suicide. Next slide. So then the next question is, we have great screening tools. We are already doing depression screening, 12 and older, well-child checks, or when patients are presenting to us for mental health concerns. But guess what? We're missing it. And we already know the stats. I think we need to do a better job when it comes to screening for suicidality. And AP has come up with a blueprint for youth suicide prevention. And according to that blueprint, and I think all the research kind of talks about, that we need to screen them more frequently. And kids who have no history of suicide risk, I think the parameters are kind of broad, screening no more than once a month or less than once a year. So somewhere in between, as a practice, you can come up with how often we need to screen them. So typically, if you look at the ASQ toolkit or through the National Institute of Mental Health, the general recommendation is that we probably should be screening 10 and older who are new patients to us, who are existing patients who have not been screened in past 30 days, who had a positive screen during the last visit, and as clinically indicated. So it does increase your, kind of the criteria that you are screening these kids more often. And that way you are non-missing. Now, this also means that, well, if a kid is coming for sore throat, do I need to screen them for suicidality? Well, it's not a bad idea. Again, kind of looking at how you want to structure your practice and what type of support and resources you have available. But I think it's really important to change the way we approach screening for suicidality. It's like a vital sign. We all know that a kid in your practice has a high chances of dying by suicide instead of dying for any other medical condition. And that's the reality, and that's the landscape we are in. So the screening does make it really important. And between those parameters that we have, how often we screen, I think it's really good to develop something where you include that in your workflow, screen on a, depending on how patients are presenting, what support you have to kind of make it as a vital sign that you have to obtain on a patient, regardless of the nature of the visit. And then one of the other things is you want to administer screening where patients can be honest with you. Okay, next slide. So the other our concerns always be sometimes we struggle with, and that's the reality. During residency, we sometimes we didn't get a whole lot of training, and And we kind of have learned it on the job. And how do we take care of these screens? So when it's a positive screen, sometimes you worry, oh my God, the kid says that they want to kill themselves. We want to make sure that anytime the kid is saying, I want to hurt myself, it's not an emergency. And this is one of the things, could be the barrier where teens don't want to tell their doctor because they worry that my doctor is going to send me to the ER, or they're going to judge me, or they're going to sort of not understand, and something like that. So what's really important is a kid telling you that I want to hurt myself is not an emergency. We really need to be present, mindful, engage with them. Important to assess for risk and protective factors, and important to provide hope. And really focus on the strengths, and kind of talk about, I understand what you're going through. Tell me about your support system, tell me about your strengths, and tell me about your overall, how things are going. So it's important to assess for risk and protective factors. And one of the important thing is to include a caregiver in the safety planning. And I was at a conference in PES, and this was a topic that was really discussed. And one of the questions was always, well, we have this teen confidentiality. And if a teen is telling me that they want to kill themselves, and the teen says, well, I don't want you to tell my parents. I just don't want them to, I don't want you to tell them. And sometimes it's like, what do I do in that situation? So the big thing is that we need to make sure this kid is safe. And the way we can approach that, when a teen is telling you, I don't want to tell my parents, or I don't want to, talk to a caregiver, the way we kind of approach it, and the way I try to approach it is, I understand your hesitation around it. I try to gather more information. Tell me why you have that hesitation, or what's going on. Tell me more about your relationship with your parent or caregiver. Oftentimes, the reason they don't want to tell their parents because they don't want their parents to worry. They don't want their parents to judge them, or they don't want their parents to sort of think that they are doing this for attention. And this is an opportunity where we as a provider can really help teen understand, and maybe help parents understand what we are trying to achieve for this patient. And the approach is safety. My job is to make sure that you're safe. And my job is to make sure you're getting all the resources and support to get you the help you need. And the reason I'm approaching your parent is because I want you to be safe, and I want to make sure that you feel that you're not alone in this. We are all in this together, and we're going to do whatever is necessary to make sure you're safe. And that including parent and caregiver is all about safety. And a lot of times I have had, unless the teen is, there's something else going on which is really more related to the safety, often all the time the teens are open to this conversation because they feel like there's somebody's going to support them, and then you as a provider are going to help bridge the gap between the teen and the parent. So that's really important to include that during your conversations. Next slide, Alyssa. And the other take home is approaching suicide risk assessment, kind of similar to asthma action plan. I think everybody knows asthma action plan. And even if with our eyes closed, we know what our green, yellow, and red zone are, and where we have to send this kid to the ER, where we can sort of send them home and talk to them about triggers, talk to them about a plan. I think we all are so comfortable with that. And I think we need to start approaching suicide risk assessment similar to that, kind of identifying which kids I need to send to the ER, which other kids I need to send them home, and who needs what, and who are the ones I need to worry about, who are the ones that I feel like they're going to be okay. Because suicide risk and wanting to kill myself is not a trip to the ER. Just like a kid who's wheezing is not a trip to the ER. When the kid is wheezing, we listen to them. We assess all risk factors. We look at what the presenting condition is, what is the family history, blah, blah, blah. We kind of go through all of that, right? And that's how we all do. And I think we need to approach suicide risk assessment in that setting, and kind of look at the whole picture. And we're going to talk a little bit about what that risk and protective factors are. Next slide. Okay. So this is a great tool, just like the asthma action plan, you have all the check marks and what's green, what's yellow, what's red. This is a great template that we can use in our practice, which is your brief suicide safety assessment. And it has a template about the questions to ask when a kid discloses with the suicidal ideation. And so the questions are around frequency of suicidal thoughts, and tell me more about these thoughts. Tell me about a plan. Tell me about your previous attempts. Tell me about overall mood. Tell me about some psychological pain, helplessness, and how you're feeling. And then you also want to talk about plan, talk about capability, talk about access to lethal meals or suicide attempts, and talk about, have you lost a family member, any history of substance use, talk about, as Dr. Briggs had mentioned, extreme agitation or rage or mood swings that are happening, and talking about, you're having these thoughts, how frequently. If they're telling you, I'm having these thoughts all the time and I don't know what to do, I think that's a big risk factor. And then talking about the intent. I want to kill myself. I have a plan, I have access, and I really want to do it. And that is really your intent. And most of the time, your teens may not give you the whole intent kind of thing. A lot of times there's going to be ideation and a plan setting, but sometimes you do get these kids where they may not say, I want to kill myself, but then you get more history. They're probably doing some things around some behaviors, like they're giving away their stuff, and they're like, I don't care, I'm just giving away my stuff. I don't care what others think about me. I don't want to keep anything, and I'm just giving everything out. So those are some of the red flags that we want to sort of keep an eye on. And then important to talk about connectedness. What are support systems you have? Tell me about your family dynamics or your friends, your teachers, your mentors, talking about their values or shared beliefs, and do they have a sense of purpose? Are they looking forward? Are they future oriented? So those are some of the protective factors that we need to talk to them about. Next. And so once we gather more information, we can then sort of triage them, whether it's a green zone, yellow zone, or the red zone, just like our asthma action plan. So the low risk is typically you have a kid who is suicidal ideation. I'm just having these thoughts. No plan, no intent. There's no access to lethal means. There's no guns, or guns are locked and away, and kid doesn't know how to get it, or medicine cabinet is secured. You have a parent who's really supportive, and they are pretty much know the risk factors. So those are the kids you can sort of talk to them about, this is what's going on. And, you can always screen them for depression to kind of know if there's other risk factors like mood disorder. And then you may want to figure out a plan around behavioral health support, and sort of really talk about some coping strategies. And I know this coping strategy or psychoeducation can be a whole topic by itself, but I think it's important that as pediatricians and us, and something we do even as a medical provider, really give them the tools. If you're having these thoughts, I want you to do these are your coping strategies, kind of work through some of those things. And that doesn't always mean that's a mental health provider's job. I think there are still some things that we as a medical provider can do and support them as an adult and give them some strategies to help deal with that while we are waiting them to establish care with a mental health provider, which I know it's just the way things are, and it could take many weeks. So as an office, when you're sending this kid home, make sure there's a follow-up contact, and not the kid is, follow up in 3 months. I think this is important that we follow up a close contact. It could be a phone call, or it could be a telehealth visit, or it could be in-person visit, however we want to set up. But it's important we touch base with the kid, because the message we are giving to this kid is that I care about you. And thank you for sharing that you were having these thoughts. And I'm just wanting to kind of make sure you're okay. And that itself is such a positive thing for that teen, that somebody really cares, and that, that the kid is not alone. And then so follow-up contact can be an important way to kind of touch base with the teen. Next slide. And then we have the yellow zone. Yellow zone is where you have a kid who has thoughts. They may have a plan. I want to overdose on pills. Not sure about the intent. May say, I want to hurt myself. I want to overdose. And no, I don't want to kill myself. Excuse me, I don't want to kill myself, but I know I want to I have had thoughts about killing myself by overdosing. And then you want to assess for access to lethal means. So getting information, is there any, things that they can use for suffocation, medicine, or any guns or any other knives or anything around in the household, and kind of looking at the risk factors, depression history or substance use and all those things. And protective factors can be around, maybe they're already in counseling, maybe they have supportive adults, they have someone they can reach out for help. And then these are the, and care planning is something that we want to do with this patient. And Dr. Briggs will sort of touch base on that. Care planning is really about assessing for, you have these thoughts, and I understand, you may have a plan. And as long as you have a teen and the parent and you have a plan in place as how we're going to keep the kids safe, these are the kids you may want to initiate a care plan and keep a close eye. Obviously, they need to be seen by someone and keep a close eye on. And so this is where the intermediate risk is, it becomes important to do care planning, although we should do care planning for also the kids in the green zone, to kind of talk about triggers and other things. The red zone other one, I think these are pretty straightforward. The red zone other one, you have a plan and they have an intent, they have access to means, and then multiple risk factors, and there are no protective factors. Like this is a kid who does not in therapy, the parents are not involved, there's nowhere this kid can reach out, and the kid is really depressed and scored really high on depression screens, and this kid is really having frequent thoughts and has engaged in previous attempts. And this is a kid you want to kind of really send them to the ER or send into crisis center. When these kids are in the clinic, make sure somebody is they're not alone, and make sure there are no dangerous objects in the room. And they're not a runaway risk. We've had that where, unfortunately, we had a kid locked themselves in the bathroom, and that was a whole thing. So it can happen. So make sure when you have a kid talking about that, just you have something in place to make sure this kid is safe, and kind of engage whoever is involved in the patient's care. Next slide.
So I'm going to talk a little bit more in depth about care planning with an adolescent and what that looks like. And I'm using the Stanley Brown model here primarily as an example. And I will say too, in the yellow zone, if you can initiate a care plan and the patient and family can engage in it, and you feel pretty secure in the care plan, that it will be followed, that's an appropriate step. I would say, where you're kind of in the orange zone, right, between the yellow and the red, is where you can do a care plan, but you don't, your gut is telling you that something is off, or you're not quite sure that the patient or the family is fully engaged in this plan. Then of course it's always appropriate to send on for an emergency assessment. And I think as far as the red zone goes too, like another thing to consider, which has happened, is that, if a patient is in that zone and the family is refusing to take them for an evaluation or address their safety, that is a DCBS call. So in developing a care plan with a family, things that we have in this plan include, what are the warning signs that this particular patient is in crisis? And so, some, different patients have different triggers, different warning signs. So talk with the patient. How do you know that you're approaching your crisis? What are your warning signs? What coping strategies, are effective for you? If they don't have any, one of my favorite ones is 5, 4, 3, 2, 1, which uses your senses. So 5 things you can see, 4 things you can touch, 3 things you can hear, 2 things you can smell, and 1 thing you can taste. And you go through and you focus on those. So you don't have to remember the exact order. I think it probably took me like 1 year maybe to remember the exact order for myself. The idea here is that you are focusing directly on pleasant sensations in your environment, or even just sensations in your environment, and that can help disrupt agitation and panic. Breathing is a common one that's given to kids. It's really hard to do if you're panicked. So first you got to kind of get back down to earth. Distraction strategies. I think, here we talk about, okay, who are friends and family who can be contacted, and we want 2 levels here. We want friends and family who can distract them from suicidal thoughts and maybe, and urges, maybe they don't have to talk to this person about what they're thinking or going on. They're just like, maybe a friend they can play a video game with online who they have a good time with, or, maybe it's a family member who will just sit with them and watch a show, but they don't have to necessarily, talk about what's going on. And then who are the friends and family who they can discuss these thoughts and urges with openly, who they can go to for support. Are there social settings they can go to where they feel, safe and secure? What activities are there activities they can do or they can engage in? And each teen will have kind of a different flavor of, some say music, some say video games, some say doing art or drawing or coloring, some say reading, right? It just kind of depends on their personal preference. Some say playing with their dogs. And then health professionals and agencies with crisis support. So we have 988 now, right? So that should be, listed in there on the care plan, as well as any other relevant crisis lines for LGBT youth. The Trevor Project crisis lines are great. They have both, they have chat and text too, which is good because not a lot of our youth feel comfortable with calling on the phone. And again, 988 can be texted as well. And then again, we want to make sure that their environment is safe, right? Ask if there are guns in the home, ask how they are stored. There's a resource at the end of this presentation for a link to where free gun locks can be accessed. Again, and I think, the best thing would be if there's another environment where if there are guns, where they could be moved to another family member's house, because even if they are stored securely, we may not want to assume that the teen doesn't know how to access them anyway. That was a loud pop of the water, sorry. I think the thing to keep in mind too is that when survivors of suicide are interviewed, most report kind of having, this initial response or initial regret. They've interviewed survivors who have jumped off, the Golden Gate Bridge, for example, and those who have survived those attempts have reported that their initial thought or feeling on the way down was regret. And so we want to make sure that, where we have the environment safe, where, a decision like this is difficult to make and go through with. And I think another thing to keep in mind is that we want to make sure our patients are prepared to cope with a crisis, because the crisis can happen fast, and the point between when the decision is made and the act can be very short. In most cases, the point between the decision to attempt and the attempt is less than 10 minutes. So we need to make sure that our patients are prepared prepared with a crisis plan. We want to make sure that they have a copy with them and it's in an accessible place. Sometimes we'll have patients, like we have it on a piece of paper and they'll fold it up and they'll put it between their phone and their phone case. Sometimes they'll take a picture of it so they have it in the photos of their phone. But we want to make sure it's with them and accessible, folding it up and putting it in a wallet, keeping it in a purse, wherever it's going to be, where they're going to be able to access it. You can provide the parent with a copy as well. Again, we value teen confidentiality, but when it comes to risk of harm or end of life, that we involve the parents or caregivers. And then again, we want to make sure we're following up with the patient and revisiting the care plan. Usually, ideally the teen has tried it and they'll be able to give feedback as to what worked and what didn't work, and then you can troubleshoot from there. There are some other safety planning apps that are out there. This is a teen who has a phone and is prone to use apps. There's a Stanley Brown safety planning app that can be used. And there's also My3, which has just kind of a way to have programmed in those contacts that the teen can reach out to, in addition to crisis lines. And again, I'll go through just some resources and links here. The Partner for Children's Mental Health out of Colorado has some great resources and training. There are some toolkits toolkits out there that are linked to on their website, one for primary care and one for schools. There's the link for where you can access gun locks free of charge. Through Zero Suicide, there's a course on counseling on access to lethal means that can be accessed. The AAP has a blueprint for youth suicide prevention. Again, some other links to toolkits as well. The one for primary care, and then the one for the ASQ.
Yeah, and I just wanted to mention the ASQ toolkit has information about how you can implement protocols in your practice. So they have a separate sort of protocol for inpatient setting, ER setting, and ambulatory setting. And it is a lot of information out there that can be adopted in your clinical practice, depending on how you would like to have your workflows in your practice.
Very good. Thank you both. So we have a couple of questions. I think some of them actually Dr. Briggs answered on the online chat. There is one here about what recommendations do you have for parents of a teen who refuses to follow a care plan, so take prescription medication or go to therapy appointment?
So if it's the teen who's kind of refusing to follow through on the plan or refusing to engage, I think that depends on where the teen is at, right? So I think you can explore conversations, if the teen is at more the yellow, kind of in between area, yellow, orange, right? I think it would have serious conversations about a higher level of care, right? So if we can't engage in outpatient treatment, then we need to be looking at either a brief inpatient stay or residential treatment. For a kid and for a kid who's maybe struggling with mood and maybe doesn't have suicidal ideation and doesn't want to take prescription medication and doesn't want to engage in therapy, I would really make sure that they have a lot of protective factors on board. So, making sure that they are engaged in at least one extracurricular activity where they have connection to peers, making sure they have, regular contact with friends, making sure they have some other positive things going on, and then making sure that they know how to access ideas for coping strategies too. There's a lot of great apps out there. There's many different ones with good coping strategies out there. One of my favorites is Mind Shift, MIND, SHIFT, for access to coping strategies. It's more anxiety specific, but the strategies they have in there are great. And there's a really cute one that's out there that has some good helpful strategies called Finch. It's basically like a little Tamagotchi of self-care. Like you get your little birdie like grows and stuff if you do different self-care activities and you record it. I know it's kind of cute, but there's lots of different ones out there, but I would make sure they have access to different resources and connection to their peer group and community.
Thank you. Any other questions that haven't been answered? I think some of them got answered in the chat box. Well, very good. We want to thank everybody for attending today. Appreciate both speakers for taking the time out of their day to talk about a very important topic. We will follow up. Michelle is available and has contact information for any questions that come up afterwards. Once again, thanks everybody for their participation.
Thank you.
Thank you.
Thank you.